be able to share. Okay, I think previously, Simba, Shola did a bit of an overview. We did an overview of the SmartHIV solution. And this time round, what we want to do is really go into the detail and do a bit of a demonstration of, we can start with the app first, and then we can have a look at the web-based portal and see, showcase all the other products, the SmartHIV Manager, the Audit Clinician, and so on. Okay. Unfortunately, Shola can't make it as well, so it's just me and you. So a bit of a friendly chat. Okay.
Yeah, that's fine.
So Simba, please fire as many questions as you can, or as you like, anything that doesn't make sense. Is that okay?
That's fine. That's okay.
Okay.
Sure.
So let's get started with the app, okay, which is available on App Store, Play Store. You can download it as you wish. Now, what the app has, we've got 3 profiles. The one that's currently on Play Store and App Store. Shola showed the at-risk profile. So there's a 4th profile. Now that doesn't come standard. And that's when we start working with programs and services, for instance, like yourself. So that's where we could have, particularly for those at risk of HIV, where they could carry out a testing, home kit testing, or at a facility. And so if the HIV is negative, that's where those at risk would receive some educational material so that they steer away from any risky behaviors. If they are positive, they are then linked to care. So that's the whole the objective of at risk. And also, we can provide some prevention mechanisms can be provided through the at risk feature. But as I said, that doesn't come standard, and that's something which is available only when we're working with programs and services. Does that kind of make sense on the at risk side?
Yeah, that makes sense.
Okay, I'm gonna log in, assuming you've created your account. So you can create an account at the bottom, and I've created an account. You can create an account with your phone, mobile phone number, or an email. So let's say here's my account, just as a test. I mean, if you want, I can share my account with you so that you can play around with it yourself at some point. I'm happy to share it so that you don't have to keep creating accounts.
Oh, great.
Okay.
No, okay.
I'll do that straight after the demo. So you can set up a PIN number if you wanted to, just to keep it private. And here you are. Here you are. This is what you land into. So this is your main dashboard. We'll have a look at the details. It all kind of starts here. This is my survey. Now, whatever I show, what you see here, Simba, this is in essence, it's kind of the foundation. So everything here is customizable. Because sometimes we get questions, because Eswatini is not the same as the UK or Nigeria. Your needs are different. Okay. Yeah. Sometimes, we've had instances saying, oh, you've got far too many questions within my survey. Well, this is the full set of questions, but we can pick and choose depending on your needs. Okay. So, I mean, here, for instance, it all starts with my survey. This is where users are expected to complete my survey. It's mandatory, and it only needs to be completed full once. However, because this is a self-management monitoring tool, the idea is we want to be able to empower people living with HIV. And so we would need to collect some data so that we can use that in order to generate all the reports and all the algorithms we're using. There's about 15 categories of information over here. And so we use things like cardiovascular because we need that information to be able to predict risk of cardiovascular disease, risk of metabolic syndrome, and so on. So there's quite a bit of information that we collect over here.
Okay.
Now, what happens?
So out of curiosity, how easily can we translate this the language? Because I'm looking from an Eswatini perspective. The local language is Swati, so is it possible to easily customize it from English to Swati, or it's one of those ways to yeah?
Absolutely, because we're going to be working with DRC, so they were asking about translating it to French. Translation is really the easiest part of this of any customization, as long as we're able to have a translator who could work with us. Okay, the rest is relatively straightforward.
Okay, that's fine.
Okay. So what happens is, because we ask users to complete the survey on a regular basis, periodically, this could be monthly, quarterly, or even annually, or even just before an appointment with your healthcare professional. Okay, so this is where they can complete my survey as and when needed. So for instance, my demographics information doesn't change all the time. My vaccination status doesn't change all the time. So if I check these, it just automatically removes this from the list and I don't have to complete again. So all subsequent survey completions depends on key information of interest over here. Okay. Let's assume that you have completed your survey, my survey, maybe multiple times like I'm going to show over here. We come to the main dashboard in the app. So we've got this medication. So this is where you get your medication reminders. It's one of those popular features where it gives 15 minutes prior to your medication, there's a notification that comes up so that you take your medication on time. But what's really particular of interest is the drug-drug interaction, which I'm sure you're aware of. HIV medications interact with many other medicines, and particularly with those people living with HIV, they are prone to other diseases, comorbidities, co-medication. So what we've added is, so let's say I'm taking this medication, SmartHIV, that's my HIV medication. And let's assume that I am also, within my survey, I've also stated my other medications that I'm taking. And I've stated that I'm on some illicit drugs, I use cannabis. And again, that's part of self-management. Okay, nobody can see this app apart from me. Now it says it's highly likely that it interacts with my HIV medication, SmartHIV, but so is something simple as garlic. This is something we consume almost on a regular basis. That also seems to be interacting with my medication. So that's something I need to be extra care of. Maybe I've got diabetes and I'm using a medication called metformin. That doesn't interact with my HIV medication. So we've added this drug-drug interaction feature because we know in most parts of the world, including Africa, over-the-counter medicine is something very easy that we can get hold of. And that's just to help in terms of managing your co-medications. Now, that's the medication part, but also medication adherence. We know it's a big issue, particularly among adolescents and young adults, because we want to keep track of these adherence. So over here,
so sorry, Aaron, so that I move with you. So ultimately, you're saying this is self-management, right? It's me as a client inputting this information to say these are the drugs that I take on a daily basis. Remind me at a certain point in time and things like that. We are not saying this app is going to be interacting with an existing EMR or something. Is it? It's me capturing the information.
Absolutely, but yes, it is. Yes, it is. Yes, it's you. But we can make it interact with an EMR as well.
Okay. That's yes, because that was going to be my next question. I saw somewhere where it says out of stock. Yeah, out of stock. So
yep, it's something we can. In fact, we've already started working with an NHS trust where the app that we're developing for them, which is basically redesigning what we have, interacts with the NHS EMR so that they are able to send their laboratory results, for instance. Again, that's something we're going to get to, but I'm glad that you're asking these questions. Please, Simba, keep asking. Okay, please.
All right.
It's a friendly chat. Let's enjoy. I'm enjoying. I hope you're enjoying too.
No, it's good. No, I'm enjoying.
Okay, right.
All right.
So we're now into the self-reported adherence section. So again, based on the information that we've just collected, this particular patient is only 52 out of 120. This shouldn't be good. In fact, it's poor adherence. This patient is not adherent to their medication. We're going to have a look at the reasons why. Okay, so this is just high-level information here. The details is in the reporting section. Suppression. Well, this is communicating with our suppression database, which has all the information about all suppression-related data for all the medications, which is communicating with our SmartHIV clinician, which I'm going to show you. So SmartHIV, my expected overall suppression is 79%. I should be adhering 92% of the time, but I'm not. I'm well below that. I'm on my 40%. So there's a bit of a warning there. So we're trying to kind of self-educate the client here about their medication and what should be the expected level of adherence. There's risk calculator. I mean, I've mentioned earlier on, people living with HIV are at greater risk, are elevated risk of certain comorbidities, and cardiovascular risk, diabetes are amongst them. So we've got an algorithm that predicts your risk of cardiovascular disease. In this case, it's 3.61%, and it's a moderate risk, it's 1 to 4%. So that's kind of, it's not too high, but I should be aiming for less than 1%. And so my health advice is 30-minute exercise per day, healthy diet, stop smoking, but the patient needs to consult their healthcare professional. So there's some additional support needed there. Metabolic syndrome risk, we know diabetes, for instance, is again another greater risk for people living with HIV. Based on the two algorithms we're using, it says no, so I'm not at a risk of metabolic syndrome, but there's some educational material provided, and also the reference that we use, the algorithm we use to generate these risks. And there's other risk algorithms in the pipeline, risk of hospitalization, for instance, risk of non-adherence to medication. So they're all currently in development, and in due course we'll have these implemented. Yeah.
Out of interest, the reference link there, where does it go to? Is it going onto the internet, or?
Yeah, it does. Let's have a look.
Or is it materials that they've prepared?
No, it's here. It's here. It goes to it goes to the paper, the article that we
Oh, I
used.
see.
So
Okay.
there we are. That's the
Oh,
article.
wow, that's nice. Okay.
So some people might want to have a look at the references. That'll be
Mhm.
probably be the minority, the extreme minority, but we keep it anyway.
Wow. Okay, that's nice.
Now, there's also alerting clinicians, alerting your healthcare professional. There's two ways we can do it. One of them is the real-time connection. So the healthcare professional has the app. So I'm going to have a look at that. We're going to have a look at that later on. But there's also alerting your clinician through our web-based portal. Let's have a look at what it means. I'm going to alert. So this is for particularly in the instances where the client needs an immediate intervention. In my opinion, this patient isn't adherent to their medication. That needs an immediate intervention. Otherwise, it becomes far more costly in the future. Let's say you can either state the email or the phone number of your healthcare professional, but I'm just going to go with email. I'll share all of these credentials so that you can play with it at your own time. Okay. So that's my clinician's email address. I'm sending an alert. Alert successful. So an email is now sent to my healthcare professional. If we can wait a few seconds, we should receive an email. If it doesn't, I'll just have to go into my Yahoo. Oh, here we are. I've got it. It's here. Oh, please, remind me later. There we are. That's the email. Alert from your patient. And so this is now where we are role playing as a clinician here, we're a healthcare professional. And this is the web-based portal that the healthcare professional sees. Okay, that's the name, the last name of the patient. So there's some demographics information for me to find out who this patient is. So there's some high-level information here provided. Aha, here's the problem. Adherence is well below the 92%. It needs an immediate intervention. Let's have a look at some of the other metrics. Can you see this is longitudinal? Because July, that's when I completed my survey for the first time, and all the others are subsequent survey completions because we want to be able to keep track of these symptoms. So in terms of some physical symptoms, night sweat, the patient is doing well. Sleep disturbances, fine. There's a bit of a weight loss that's been going on since January, but general health-wise, the patient isn't doing very well. So it's fair. Health compared to 1 year ago is poor. Happiness about life. Clearly, this patient is fairly depressed. I mean, physically, he's doing fine. You know, viral load, CD4 count is fine, but psychologically, there needs to be some sort of a counseling or, you know, psychotherapy intervention required over here. So the patient is okay with memory loss, difficulty planning, and paying attention, but there are some issues around psychological support, because I'm, you know, there's a huge amount of evidence in the literature that, you know, HIV is no longer a physical disease on itself. I think there's also the mental health element. And within this particular technology, we've tried to capture as much as the mental health element as we can, because that's where additional support is needed. Well, anyway, that's how
Okay.
we can you know, alert a clinician in real time via the web-based portal.
Yeah, no, this is beautiful. I really like this. So, in terms of seeing that the data is magnitude now, does it give me a nudge now and again to say, can you please complete your survey?
It does.
You know, how frequent does it do? Is it a setting that I put, or how does it work?
It's a setting. You could either do it
Okay,
monthly, quarterly, 6 monthly, or
I
you know,
see.
whatever it is. Yeah, it is a setting.
Okay, so it's like it comes as a reminder on the app
Absolutely.
notification or something. Okay.
Yep. Just like your medication reminder, for instance, or your appointment reminder.
Oh, perfect.
Okay. Yep.
Wow, no, this is nice. All right.
Okay, so there's also the health and well-being here. So this is just your latest survey completion. You can see physically you're doing fine, but mentally there's a problem here. That needs to be tackled. Okay, so this is the latest survey completion. There's also the appointment reminder. So we know in the UK, almost 18% of patients miss their appointments. I'm not sure what it is in that part of the world, but this does happen quite frequently. So 24 hours prior to your appointment, you receive a notification just saying that you have an appointment. This is another feature that we've had a lot of positive comments from users. You know, it's a daily motivational quote.
I like it too.
Every day, users, they wake up for an inspiration. I mean, I like it. I don't know, it kind of it lifts your mood when you wake up for this kind of a quote. So we've had a lot of positive comments about this, and also a lot of comments about your information needs. So we know there's a lot of myth particularly in the internet around HIV. So again, in my survey, we have a section where users can select the information they want to receive on a regular basis, where they can, so this is in the form of articles, newsletters, even journal articles that are easy to read. So all coming from credible sources. So I might, you know, want some information about sharing disclosure of HIV status, for instance. Here I click, and it takes me to a credible source about disclosure of an HIV, you know, the WELL project. I'm sure you've heard about it. So information coming from credible sources. Any questions so far? Is it all kind of sinking in, Simba?
Wow, no, I'm just enjoying the presentation.
Don't say wow yet,
I,
because you haven't seen 1% of it yet. I haven't even started. No, I haven't even started yet. No.
You know, I like the way it's so interactive, and you know, you can base the information on research and things like that. You know, so it's yeah. I mean, it's really it really talks to you. You know, that's one thing I really.
What would be nice, Simba, is can you start visualizing how this could help all those critical key challenges? What are those challenges? Retention in care, it's a big challenge, particularly among the young and the adolescents. You can see how the app will support, and it does. You can see how it will support stigma and discrimination, because everything is within your own secret corner, within your area. It's within the app. You can see how it supports around your medication adherence, because it's still a big problem.
Yes. Even those myths, you know, around addresses all those myths. You can actually read information about all those things on your own, you know, and you know, which is good, because sometimes it's difficult for people to then ask the clinician some of these questions. But you can then sit down in your corner with your app and be able to read some of these things. It's really good, you know. It's a well thought app. Yeah. Like it.
I mean, even something simple as this, Simba, drug-drug interaction. Let's say I'm diabetic, okay, and I need to call a non-HIV specialist. Well, because of stigma, I may not be able to call my non-HIV specialist and ask whether if this medication is interacting with my HIV medication, particularly in most parts of the world. This, and by the way, this is what the HIV most clinicians use. They use the University of Liverpool, the drug-drug interaction checker, and it's here. It's been implemented.
Yeah.
So,
It is.
and also you can see how much it will support, out-of-pocket expenses, for instance. I mean, it
Yeah.
costs a lot of money for patients to travel, God knows how many kilometers, leaving their homes very early in the morning just to pick up their, medical laboratory results, for instance. Well, why don't you just send it through the app? For God,
Yeah.
for goodness sake, that will
That's true.
reduce the burden on the healthcare facility. That will reduce the burden on staff because they are working flat out. Okay,
Mhm.
and that also reduces the burden, and also because doctors can be very expensive.
Yeah.
Most African nations do not have enough doctors to be able to prescribe medication.
That's
So
true. That's true.
it supports in every sense. Anyway, let's carry
Yeah.
on. There's a lot of
Yeah.
features
So
here.
how comfortable were you? I'm just looking at your Smartalytics logo there. In terms of branding, is it something that you're going to be flexible with? Because I'm
Yeah,
looking,
yeah,
for
of course,
example,
of
in our
course, of course.
situation where donor funded, a donor would want to see their logo there and things like that. Yeah.
Absolutely. For the
Okay.
NHS, for instance, we're working.
Uh-huh.
That logo is going to be NHS logo. The blue is
Okay.
going to be NHS blue, and the pink is going to change as well. A lot of it, of course, it is. It's part of the customization process.
Perfect. Perfect. That's fine.
Simba, as I said, this is a shell. Think of this as a
Okay.
shell, as a
Okay.
foundation. Okay,
Okay.
because
All
we
right.
know the reluctance of patients downloading apps that are not directly related to their own kind of,
Yeah.
you know, logos and
Exactly.
brands. I know
Exactly.
that
Yeah.
we are very well aware of that. This is
Yeah.
just a
Exactly.
shell,
Okay. Perfect.
right? And there's also things like, I believe in education is really the way forward. There's also these quizzes. We have these interactive quizzes, where we call this, the idea is to be able to enhance one's knowledge. So they receive these kind of questions. Do you require a prescription or the intervention of a healthcare provider to use a female condom? Yes, no, I don't know. Which one is it? No?
So no, yeah.
Yep, and so that's the correct answer. So what happens is,
Okay.
a couple of days a week, just to increase the engagement, we have a
Mhm.
bank of questions all related to HIV, HIV transmission, prevention, and so on. And the idea is to be able to really educate, people living with HIV, so they have a better understanding of their disease. That's how you uplift one's knowledge in order to better understand the needs of their disease. So through education. So there's these kind of questions that comes up. Now I want to show reporting. We've just had a look at very high level results, but there's also the detail. Let's say I want to go back the last 6 months. Okay. And I want to have a look at my adherence the last 6 months. Clearly, I was rock bottom last year, September. I've made some improvement, but it's still not good enough. Well, why is it? What is holding me back? So this is something for clients to discuss with their clinicians. By the way, the clinicians do have access to this as well. I'm going to show it to you later on. Adhering to treatment plan due to side effects. So clearly, the patient has experienced some side effects. Is it time to change their medication? Integrating treatment into daily routine. That's another big problem. Sticking to treatment schedule because daily routine is disrupted. Maybe the time has come to switch this patient to a new medication because they are not adhering. And these are the
Wait,
reasons
wait,
why.
wait. Okay, so these reasons, where are they coming from? How are they populated?
Oh, they're coming from my survey. So we
Or
asked a
from the
series of
survey?
questions. That's
Also,
right.
okay, okay, okay. So you ask these questions in the survey,
Yeah.
then all right, it summarizes here.
Yeah. And the good thing is we
Okay,
ask so many questions because, because
okay,
let's not forget, not all the time they may answer the correct answer. So
yeah,
correctly.
yeah.
So this is a bit of a psychology that you use in the world of questionnaering.
I
Okay,
see.
so you can then
Okay,
start to piece together.
okay,
Okay,
all right.
so that's the reporting part. I mean, here, for instance, you've got your reports around cognitive problems. So again, over time. So these are all different completions of my survey at different time points. Okay, your viral load, for instance, this is where we could the EMR could be integrated here so that we send the medical laboratory results online via the app. They don't have to come in just to see it. Okay. Quality of life. There's a lot of metrics here. Your current health, your health compared to 1 year ago, your happiness about life. Can you see it's all, fairly bad. There is some sort of counseling needed for this particular patient. Okay, so that's the reporting part. There's a lot more other features. For instance, Simba, this is where you can start connecting with a buddy, a peer group. This could be a friend, a family member, or it could be some sort of a community health provider, where one community health within that particular support group, for instance, men having sex with men group, it could be gay groups, it could be, sex workers group, where that person could monitor the progress of patients over time. So via inviting a buddy. So what I'm going to do is demonstrate how that works with a clinician, because you want to be able to establish real-time connection with your clinician. And the same thing applies for the buddy as well. Does that kind of make sense?
Okay, yeah, that makes sense. Yeah, makes sense.
Now, this is the key, I would say, the key feature, connection with your healthcare professional. Let's assume my healthcare professional, they haven't downloaded the app. So I could invite my clinician either by stating their email or phone number so that they can download the app, and they enter their organizational information so that it comes up over here. And let's see how this works. Let's say I'm a patient in Mozambique, just as an example. So I'm in Mozambique. I'm in this particular state, and I get my treatment within this particular city, and here's my organization. Okay, and within that organization, that's my clinician here. I can tap on it, and if I tap on connect, this will automatically establish a request for my clinician to accept me as a patient. And let's see how that works. Let's assume that I've connected. Okay, I'm going to come out of the app. I'm out of the patient section. I'm now coming into the app as a clinician. So, and I have an account. That's my account. And so we're now in the app for this is clinician section. So can you see this connection request? So this is all the connections request that was made. That's the patient.
Oh, okay.
Okay. And so all they have to do is they can add me as a patient or reject if I'm not their patient. Okay. And this is where they will have a list of all the patients. And by the way, we can, you might have 1,000 patients or 10,000 patients. We can add them ourselves so that the clinician doesn't have to do all the hard work of adding the patients one by one. It's a lot of work. And here's my patients, and I can search them if I want to do. I might be treating hundreds of patients. I can search, but let's say this is the patient that came in for my consultation, and I can say, hey, there's some alerts at the top. Can you see the patient was depressed earlier on, and they had some suicidal tendencies. Adherence is well below 50. There's something wrong. That needs to be tackled. I can also have a look at, the last 6 months, for instance. I can go back and say, look, let's have a look at my patient adherence. Can you see all the stuff that I presented in the reporting section? They're all here. So the same information is provided for clinician, but there's even more. So the clinician could then say, look, what are the causes of patient not adhering to their treatment? All their viral load, the cognitive risk calculators are all here, the quality of life, but even more, depression, because this is quite important. Feeling depressed, there's more information here. There's loss of interest in life. So there's suicidal tendencies going on. At times, patient is not satisfied with regimen. So, the side effects that, some of the causes of not adhering, they are happy with their clinician, but they're not very happy with the HIV system. So this is where we start measuring satisfaction. There's also the stigma and discrimination metrics we're kind of building as we kind of speak. So hopefully in the next coming month or so, that would be available. So all the information is here, okay, for the clinician in order to, it's all part of continuous monitoring via the app in order to improve retention in care, improve medication adherence, reduce stigma and discrimination, and so on. All of those key challenges that we hear, we see all the time, but very little is done about it. And so this is where we believe that the app will make a huge difference. Anyway, that's a quick demonstration of the app, Simba, before we move into the web-based portal, because there's a lot of stuff there for me to show as well. Any questions so far? Is it all okay?
I think let's continue. This is quite okay. Yeah, I'm just enjoying the app so far.
Good.
It's good.
I mean, what I'm going to do is, Simba, I'm going to just write down over here, in fact, into the chat. This is if you download the app, that's the password. So that's the, what do you call it? The username and the password. Here we go. It's in the chat. So you can access. And if you wanted to,
Great.
and for the clinician, so I'm just going to write it, clinician account. Okay, so that you don't have to keep creating it. Okay, and the password is the same, I think. There we are. Okay.
Great, got it.
Okay. Now what I'm going to do is I'm going to stop sharing here. Okay, leave meeting. And I'm going to start sharing my web-based portal. Okay. Can you see my web-based portal?
Yes, I can.
Okay, very good. So can I just remind you what SmartHIV solution is? SmartHIV solution, the core element is the focus is on patients. We want to be able to empower people living with HIV, but whilst also supporting all stakeholders, someone like yourself, for instance, working as part of programs, clinicians, policymakers. And this is where we have all here. So you're able to access this via a username and a password. I want to start. Can you start? Shola briefly mentioned what the SmartHIV clinician a few weeks ago about supporting clinicians and healthcare professionals in terms of tailoring treatment. We've got the SmartHIV manager. It's to be able to establish the needs, and I'm going to go through that in a sec. You can have, for instance, your EMR integration. So I've got DHIS2 over here, which we're kind of integrating for Sierra Leone. You've got SmartHIV audit-lytics, but we're collecting so much data through the app. You might have 10,000 patients. You want to be able to monitor their progress. Are they in general adhering to their treatment, the psychosocial aspect of it, and so on? So this is where you'll be able to monitor all of that through the web-based portal. I want to start with the manager first. So just to kind of remind you what the manager is, so this is an interactive web-based portal. Actually, sorry. So this is an interactive web-based portal for the management of HIV services. This is where you'll be able to assess your needs over the next 3 months, 3 years, 5 years, and 10 years. Okay. The way how it works is this. It captures a HIV service, okay, within a simulation environment. It mimics a HIV service with all of its uncertainties, okay? When I say uncertainties, it captures all the variation in terms of how patients are coming in, all the resources they use, the monitoring, the treatment, and so on. And if we can capture reality to a certain extent within a simulation environment with all of its details, then we can run all sorts of scenarios in order to be able to plan our services. So we can do our planning at local level, regional level, national level, program level. So let's see how this works, just as an illustration. Have you heard of discrete event simulation before, Simba? Is this something you're familiar with?
No, this is the first.
Okay, what it is
yeah.
it tracks individual movement of patients here. Now, all the way from initial diagnosis, treatment, and monitoring. So they come in, and obviously there are resources attached when they come in. They spend X amount of time, and they receive their treatment. They go back into the community, and they kind of loop around because there's this constant monitoring of the patient. The patient is never discharged, are they? Because it's a lifelong disease. So let's have a look. Let's say we're going to use, is Eswatini in the list? If not, is it called? It could be.
Try Swaziland. Maybe
Swaziland. Swaziland.
Yeah, there we go.
Okay. So just let's do a quick, how long do we want to do our projection over the next 3 years, 5 years, or 10 years? This is all about the future.
Yeah, let's do 5 years.
5 years.
Normally we get 5-year projects.
Okay.
Yeah.
How many patients do you have in your service, Simba, or the program you're dealing with?
It's 109,000.
109. This might take about 1 minute, but let's do it anyway. I don't mind waiting for that 1 minute. Okay.
Okay.
I think it's worth waiting. 109,000.
Yeah.
And how many naive cases? How many on average of new cases do you get each year?
Each year we get about let's just say 3,500.
How many?
3,500.
3,500. Okay, 3,500.
Yeah.
So we've got to answer.
Yeah.
Okay. And then so that's the annual incidence rate for Swaziland. And let's say this is for demonstration purposes.
Yeah.
Because we are always, if you capture reality and that reality is validated and it's robust, we can do all sorts of future scenarios, future interventions. Let's say within your program, how many people are provided PrEP-PEP? Do you have a ballpark figure?
Yeah,
Just
PrEP. I can
PrEP-PEP.
Yeah, can I quickly check just a second?
Sure, let's do it.
I should have the data
Sorry,
somewhere.
Simba, are you okay to go beyond 3 o'clock by 15, 20 minutes? Are you okay
15,
with
20 minutes. Yeah, that's fine. That's okay.
That's fine. Let's carry on as it is.
Yeah.
Let's carry on.
Okay. All right. So, okay. So basically, the figures I'm giving you are for our because we're managing 2 regions within the country. It's not the whole country per se, but yeah.
Okay.
Right. So for PrEP, let's say we have about 12,000 enrollment.
Okay.
Yeah.
And then let's say we want to increase this 12,000 to 20,000. Okay. I'm just making this number up. Okay.
Okay.
Okay. And this is a significant increase. What we want to be able to do is, let's say our objective is to be able to reduce this the new infection rate. Okay, for Swaziland, or particularly your area. Okay, so we've just got all the numbers in. Okay, and for Swaziland, the costing is approximately $104. That's how much it is for ART costs per year per person. Let's not forget, this is discrete event simulation. The power is we're able to attach all of the consumed resources as they are flowing in, as they are moving in the service. Okay, and there are some confidence intervals behind that. So that's the second line ART costs. Laboratory costs around $25 per patient per year. That's the staff costs. And PrEP-PEP costs it's less than $200. Do you have a PrEP-PEP cost at the back of your mind? It says it's 200, but I'm sure it's much less than this.
Yeah, probably the person per year, maybe I don't know, around $50.
That's it. It's $50. That's what we had for Nigeria the other day. $50.
Yeah.
Okay. Now look. So that we've attached the costing, but there's also a lot of other information. Your male, female population, your age groups, for instance, we can adjust. And by the way, we can pick this up all from your EMI if we wanted to. Okay, we can connect this to your EMR, and it's because EMI is all about the past. Manager is about the future. So that's what we're interested.
Okay.
Your prevention breakdown, let's say 75% are prescribed PrEP, 25% PEP. Okay, treatment times. This is very important. The amount of time a healthcare professional, either a doctor, a nurse, a counselor, all of the amount of time spent by each of these healthcare professionals is allocated here. How many times these patients come back? 8 times for new cases, twice per TX experience, those pregnant cases, and so on. These monitoring visits. Okay, we are capturing reality, Simba. Please make this clear distinction. I'm going to run this scenario, now. Let's see what it looks like. This might take about a minute or more because you've got 109,000 patients, plus, in fact, we're doing it twice. It's going to run scenario 1, which is your current practice as it is, and it's also going to run for your scenario 2, the intervention. So before Swaziland goes ahead with 20,000 PEP prescriptions, okay, offered for those at risk, we want to be able to find out the impact this will have on every single aspect of your of the HIV program. Okay, it might take up to a minute or so. Okay, a minute or two. Do you have any questions so far about this particular aspect?
No, this is clear. I'm just curious
We've done
to
it.
see the results.
We've got the results. We've got it. It took less than 1 minute. By the way, Simba, this is the first of a kind technology, a simulation where you're able to run hundreds of thousands and millions in the space of a minute. Normally, this takes in excess of 24 hours to generate the results, in excess, even with the most powerful computers.
Okay, that's good.
So at present, you've got 111,000. So, okay, by the end of this 5-year period, okay, based on your 12,000 PEP, okay, you're going to have this many patients by 2026. However, if we increase it to 20,000 PEP, it's going to come down to about 105,000, okay, because of the number of averted cases. You expect over the next 5 years, 1,754,000 or thereabouts visits to all of the HIV services. Whereas in the case of scenario 2, you expect 1,933,000 because of the number of PEP cases. There's an increase there, okay? And the total hours is about what? Just over 2.2 million hours of staff time utilized. This is very high level set of results, but it's the detail that I'm interested in. So let's have a look at that. So this is all part of your planning. This is looking at the past 12 months. So you've got this many TX experienced patients, 109,000. You've got about what, 3,500 naive cases. You expect 97% adherence. Your age class breakdown, it may not reflect because we haven't changed the age groups, okay? But this is what I'm interested in. What happens each year for the next 5 years? So can you see this in scenario 2, you can see the number of TX experience coming down. Okay, but let's have a look at the new cases. What's happening, Simba? You expect about 2,500 patients to be in the year 2022, this year. Okay, that's the number in the year because you've got 12,000 PEP. But if we increase to 20,000, look what happens.
Yeah, it goes down.
It goes down. So by the end of year 5, you have significantly reduced the number of new infections as a result. So number of deaths, number of discontinued, number of patients for each of these years, always comparing the two. We are always comparing your current practice against the scenario. Okay, so your naive cases, those on PEP and TX experience, number of visits to the clinics by age group, okay, for each of those years, and so on. What about your staff requirements, human resource needs? So we expect about what, 166 hours of doctor's time, clinicians, healthcare professionals treating patients, okay? In the case of scenario 2, there's a bit of a reduction because of new infections we're preventing. We need about Well, it says available number of doctors against the required number of doctors. Let's not forget, this might change because the input parameters for Swaziland is not the same as other countries, okay? But what we're also saying is we're able to kind of pinpoint the exact number of staffs, doctors, nurses, counselors, okay? And the detail is here. So how many hours of each of these staff would be working over the next 12 months, comparing current practice against scenario, the
Okay.
5-year plan.
So in our case, for example, we find out that HIV management, especially public facilities, it has been shifted to nurses rather than the doctors. So is there a way we therefore we can shift those hours from from the doctor to the nurse?
Yes. What will happen is, Simba, is when we deploy this solution, we will update all the SmartHIV input parameters. There's about 100 of them directly related to Swaziland. Okay, your service. So we have a template of all the input parameters that we sit down around the table, update it, and make sure it's all customized for you, okay, and validated so that it's ready for use. That's why this is just a demo. Okay.
That's okay. No, I just wanted to understand if it's
Sure.
possible to alter.
Yep. So it highlights where you've got staff shortages, staff excess for each of these staff types. Okay. So on different type of scenarios, it goes into your 5-year plan for each staff type. How many of these do you need? How many hours they work, and so on. Okay. So if there's also UNAIDS, so we can run scenarios around, if you're targeting for UNA, UNAIDS 90, 90, 90, where you should be, number of patients you should be targeting, number of diagnosed on ART, on viral suppression. So there's lots of outputs related to UNAIDS as well. Okay. So if you're wherever you are on the UNAIDS cascade, you can kind of run scenarios on that. There's also prevention here.
Oh, that's nice.
There's prevention. So we've just run a scenario on prevention. So we want to be able to have a look at this in high-level results at the top. And the one that in particularly that I look at is number of averted cases. So for those on PrEP, if you carry on as it is in this year, you should be reporting about 737 cases. Okay. Whereas obviously in the case of 20,000, you should be able to avert about 1,274. So how many averted cases each year? Number of visits as a result of PrEP. And the one that I value the most is the one at the bottom, is cost effectiveness analysis. Is this a cost effective intervention? Let's have a look. Well, hey, yes, it is. Increase from 12,000 to 20,000, Simba, is a cost effective intervention. Okay, your difference in averted cases is about 7,740. And the difference in total costs, your savings, how much each of them is going to cost you as a result of this intervention. So there's a health economic analysis going on here in order to help with your analysis, your decision making. Okay. There's lots of outputs around budgeting. Yeah.
I'm just thinking in this case, we're mainly focusing on PrEP. What if we want to also include other parameters like VMMC, for example? Can we be able to do that analysis?
Yes, we can. In fact, we've already added that, but they haven't deployed. So we can do condoms, education. We can do all other, as you said, male circumcision, for instance.
Okay.
Yeah, we can. Okay. It's fairly flexible in that sense. There's lots of results around budgeting here. It's costs by age group, costs by expense type, costs by laboratory costs, staff costs, and so on. So this is all about financial planning. Okay, so that's the SmartHIV manager in a nutshell. There's a few others that I want to demonstrate as well. Okay, any questions before we move on?
No, I'm good.
Okay, let's have a look at SmartHIV Auditlytics. I'm just kind of jumping in between because I value the data that we're collecting through through my app, through BSmartChart app. I'll say it again. HIV is no longer a physical related illness. I think it's more mental health related illness. And it's important we're able to keep track for instance, of your 109,000, how are they doing? So I want to be able to slice and dice my data that's collected through the app. This is an ongoing, so we haven't deployed the complete version, but I just want to kind of just a quick demo. Maybe I'm interested in a specific age group within that 109,000, specific key population, okay? And that's possible. But for demonstration purposes, let's say I'm going to select all of these patients. All I'm doing is now I want to look further into my data coming through the app. I can have a look at those people with specific comorbidities, okay? And we know that most EMRs do not provide this level of service because they don't collect mental health related data. I don't know why. It's in my opinion, mental health related metrics are in fact even more important than physical health. I mean, the vast majority of those people on ART, they are suppressed anyway, but it's the mental health aspect of it. They need a lot more support. So this is where you're able to kind of keep track of, for instance, their emotional well-being, their psychosocial state. So this is where what we do is where you can slice and dice your data. So imagine in this case, you're going to be Swaziland, but let's say I'm going to pick Nigeria. Okay. So you'll have all of your patients broken down by different states in Swaziland, number of patients by states or city, whatever you want to see, how many of them are suppressed, their suppression status, okay? And there's lots of information around, for instance, their comorbidities. So, this is quite important because I can then keep track of all the comorbidities that my patients are facing with. Their co-medication, for instance, again, is something that we need to keep track of, okay?
So, sorry, just to cut you in. Suppose I want another visual which is not part of this package. Is it how possible is it to do custom visuals, or is it something that we might need to interact with the developers?
No, everything you see here are customizable, Simba. Everything.
Oh,
okay? Because as I said, this is a baseline, and the needs of Swaziland is not the same as the needs of others. So yes, these are all customizable.
No. As in after you guys deploy, then I decide later on I need such and such a visual on my dashboard. Is it something I can do on my own, or we would need to interact in that regard?
No, we will do the development during the customization process. Okay.
Okay, that's fine.
Okay, right, let's carry on. Right, and so what we're adding is in development, but over here we're adding emotional well-being, mental health state related metric, dashboards. That's going to be helpfully in about a few weeks later. That's going to be ready. This is where you'll be able to see, the progress over time of your patients in terms of their mental health well-being. Okay, so that's the auditlytics. Does that kind of make sense? What the objective audit is? It's all about the auditing and monitoring and the progress of your patients.
Yeah, no, it does.
Okay, and finally, I think we're kind of almost on time. Is we've got this SmartHIV clinician. Now we know in most parts of Africa the lack of doctors and clinicians in particular. It's where they've been given the responsibility to prescribe. What we've also developed is we've developed some sort of a tool called SmartHIV Clinician. The idea is to be able to provide the best possible treatment outcomes with all disease-related complexities for patients, because patients are aging with various comorbidities, and the idea is, how do we select the optimal ART? How do we personalize this? So here's an example. Let's say I've got a patient. So for every patient that comes through the door, I can use this so that I can personalize the treatment. So an adult, a male patient, a non-white patient, for instance, and it's a new patient coming in. So just very recently diagnosed. And this patient is on, let's say, I'm just going to make is an anti-diabetics. So I'm going to use that. This patient is on anti-diabetic type of a treatment. I'm just going to give a few. So herbals, I just will select cannabis from the list. okay, an illicit recreational drug. So let's say I'm going to select metformin. So that's my diabetic drugs that I'm on. And I'm also on some folic acid, maybe, or it's garlic. Let's say, let's stick to garlic. And I'm also on an illicit drug called, let's say, cannabis. Where is it? Here we are. Here we are. And I want to click on clinical outcome. So what this is doing is that it brings all of the existing clinical trials that's been conducted since 2015, all of it. And all of based, we're talking about thousands and thousands, in fact, 74,000 journal articles are screened with a database at the back end, which has information about all of the conducted clinical trials, about their broken down by patient attributes and their suppression information. So I've got all of these 5 ARTs that is recommended now based on this information provided. So for someone who's an adult, a male, a non-white, a new patient, the system is recommending these 5 ARTs because that's got these have the highest suppression. And so it kind of breaks down by some of those key attributes. It's broken down by week 24. Over time, you expect these are the suppression by the week 24, week 48, week 96, and week 144. So a bit of what it's doing is it's just providing all the best possible outcomes. So in essence, the treatment is kind of tailored to individual patients' concurrent diseases and concurrent conditions, medications. So if I scroll down, for instance, so for each of those ARTs, these are the expected chance of drug-related adverse reactions, expected patient adherence. Okay, but what is important here is these two, really, in particular, the interaction, because I need to be able to say, look, you can't prescribe any of these medications apart from this because it interacts with garlic and metformin, okay? And it doesn't interact with cannabis. It's all about balancing. It's all about personalizing the optimal ART treatment, just bearing in mind all those comorbidities and co-medications that's been taken into account. However, if I look at this, based on drug-drug interaction, this is what TDF FTC's recommended, but let's have a look at serious adverse events. If I come down, well, the problem is how do I, it's a balancing act. The serious adverse event, this is quite high. Okay, now this particular drug is the best when it comes to drug-drug interaction, but there's also serious adverse events. It's all about supporting healthcare professionals, particularly in most African nations where there's limited number of doctors, limited resources. Again, this is not to replace clinicians, but this is to be able to support them when it comes to prescribing medication. So that's just a bit of about a quick demonstration about SmartHIV clinician. Does that kind of make sense, Simba? Was it?
Yeah, no, yeah, it really makes sense. Yeah, I can follow through. But more than
Anyway,
anything, I just enjoyed the the mobile app. To
that's good.
say an individual has the responsibility to actually manage their own treatment. And for a start, we're seeing a situation where you don't really have to be told what to do, by the clinician. The clinician needs to do an assessment. You do your own evaluation. You do your
Yeah,
own assessment. Basically, you can control your health, your health care at the end of the day. So that's a very, very interesting concept that I haven't seen around, and yeah, I'm really intrigued.
I think the next thing what we want to do, Simba, is how do we go about deploying this solution, if possible, in Eswatini? If there's
Yes, yes. Actually, that was my next question to say. In terms of deployment, what are the deployment options? Because I see it's heavily internet based, but looking at most of our facilities, we don't have good connectivity. I don't know. Do you have any experience in other African countries? How did you handle it?
Well, no, we've had some great, actually, we've run some pilot studies in Nigeria and Kenya in terms of internet connectivity. We had absolutely no issues whatsoever. Let's not forget the app. So let's start from usability, okay? We, in fact, let me just, quick, if I can stop sharing something, I might, can you just give me a few seconds if you don't mind? I'm just going to bring up a slide about our
Okay.
use cases I think that's important. That's
Okay.
really important. Okay. I'm going to reshare my screen again. Can you see my screen?
Yes, I can see it.
Okay, so what we've done is we've intentionally run pilot studies with all ages and all sorts of education and background. Okay, so all the way from, so we had just under 100 users, which is statistically a good size, okay, from different parts of Nigeria, well-educated, not well-educated in Nigeria and Kenya, which is a good sample, actually. It's not a bad representative of generally in Africa. So we've had those people who are very basic, no formal education with all the way up to master's degrees. We had age groups from all the way 18 to about 65 plus. Again, the vast majority of the patients. And what we wanted to do is to be able to assess their perception and usefulness. Okay, and so if I can go to the next slide. Can you see the average satisfaction index of all of these? So I'm just going to, you might not be able to see, but support daily management of HIV disease. What these people thought was about 90% of them. So 90% of these gave us a very high score, satisfaction index. So you can see that support in terms of monitoring their regular outcomes, for example, suppression, that's in excess of 90, it's about 95%. So in terms of usefulness, people with all sorts of background, very poor background, people with medium level, with very low education, generally speaking, the average satisfaction was very high. Okay.
I'm just curious, did you have a question for mental health and how it assisted in mental health issues, and what was the percentage? I can't read the questions, unfortunately.
I can provide you this I can't remember, but we did have something around their stigma and discrimination. Within that stigma and discrimination, there was a mental health element as well. So it was quite,
it would be interesting to see the results. Yeah.
In fact, I'll share the paper. We've submitted the paper for publication. I'll share it for you too, if you don't mind, if you can have a look,
Okay,
which has
great.
all the findings. Now,
Okay.
coming back to your internet issue, the issue is the app only requires internet connection when you're two things: when you are creating an account and when you're completing my survey. And all the other features does not need internet connectivity. We've also seen cases where patients, for instance, they go to their community support groups where there is some internet connectivity provided, internet connection, if they wanted to establish a connection with their healthcare professional, for instance. Okay.
Oh, okay. That makes sense. Okay.
So we initially thought this would be a major issue, but it's not actually. There are solutions behind these kind of problems. And in fact, amongst all of these participants where they provided us feedback, none of them came back saying we don't have internet connection, because it does not require huge amounts of data just for you to be able to make use of the app.
Oh, perfect.
Okay. And even something as simple as Simba, let's not forget, it takes, look, we did some sort of a study at a single center in Nigeria with 7,500 people living with HIV. So we assume that we give an app, so we buy an app, we purchase an app for people who are stable on ART, and where medical laboratory results are delivered via the app instead of traveling. Now, these people travel long distances, which costs about $5 to $10 because they are missing out on the day's work. They have to travel long distances, the food and so on, but it costs them up to $10 a day just to be able to pick up their medical laboratory results. Well, the app, I mean, that on its own saves huge amount. Look, is even to the hospital, to the service, at the worst case scenario, 14% in the number of visits is reduced to the healthcare service provider. 39% of a doctor's workload, 42% of nurses' workload have reduced. So look at the amount of savings as a result of the app. Okay, both on patient, because they don't have to travel long distances, and in fact, it would cost much lower just to pay for your data, for instance, in a year, as opposed to traveling to pick up your medical laboratory results. Does that kind of make sense?
Yeah, no, true. It makes sense. It does.
So in terms of usability and user feedback, we've got lots of evidence, lots of data. We've had no issues whatsoever. In fact, some of the comments and feedback has just been amazing, and I'm happy to share some of that with you.
Okay, that's fine.
Okay. Any other questions? I mean, how do we want to move forward if we wanted to move forward with this now?
Yeah, so I'm not sure if the information you'd shared information in terms of around costing and all those things with our HQ team. I'm not sure if you're at liberty to say it, but I don't know. I don't know. Has there been a discussion around costing and anything along those lines?
I mean, do you want me to provide some costing? What I can do is I can give you an example. Okay, hopefully we're going to be deploying this solution, working with an implementing partner in Nigeria. That would be CDC funded if it goes through in October. So we costed for 140,000 people living with HIV. Okay, so this will be deployed, and we gave them a cost of, I can't remember the exact, but $12 per patient, but that is a perpetual license. That means they will have access to this app lifetime. And so this will give them a lifetime access to the app, and obviously with all of this facility, all of these features and functionalities. Okay, and so there is the 12, and there is the plus the customization costing on top of that, because we would need to customize the app and some of the features, for instance, Auditlytics, the SmartHIV manager, so that it's fit for Swaziland rather than Nigeria or any other country. Okay, so that's the kind of the costing framework that we have. But obviously some of these are negotiable.
Licensing, do you have any yearly licensing for the dashboard particularly?
So the yearly licensing will be, at the moment, is costed at £5,000, but that's organizational license. So that's open to everyone in your organization. Okay. But then again, a lot of it is kind of negotiable. Okay, depending on the kind of the size, I would say. Okay.
That's not bad.
I mean, come on, there's crappy apps where they charge $40, $50, $60 per year. I mean, it's absolutely useless. Whereas I can put my feet and say, by far, what we have is this is the most advanced app in the market that will have a direct impact on patients. I mean, the $12 that I just mentioned, forget everything. Just out-of-pocket expenses is being saved by paying for once for that patient traveling long distance just to pick up their laboratory results. Not to mention the amount of doctors and nurses' time that's saved, which is in the region of hundreds of thousands of dollars or even millions.
Yeah.
I mean, I don't even have to do a cost-effectiveness analysis for this. It's just a no-brainer.
Yeah, that's true. Yeah, no, I think for the value you get for the app, the demand is not that much.
I mean, the thing is, I mean, I'm now kind of intrigued and want to find out how we want to how do you want to report this back to the HQ? Maybe you want to use this, obviously, video or this that we're recording. Maybe they might want to watch it. Arnold might want to watch it. Okay, I'm gonna. In fact, I'll stop recording so that I can have this uploaded to. One sec.
Yeah, so definitely this video will be perfect for the start.
So I'm just